Hello, hi everyone. My name is Dr. Syamhanin Adnan from Hospital Sungai Buloh, Malaysia. I'm going to talk about antimicrobial stewardship during the pandemic. What is the challenges and how do we go about in implementing antimicrobial stewardship during pandemic? So this is the outline of my presentation. First, I will talk about the trends on antibiotic use during the pandemic and also factors that contributing to the overuse of antimicrobial during pandemic and what is the impact of this towards antimicrobial stewardship program and also some data from our own hospital in Sungai Buloh. Also the challenges in implementing and case studies in implementing antimicrobial stewardship during this challenging time, and also the last would be the important key areas in implementing AMS. So data on antibacterial usage during COVID-19 is being discussed in this paper, where it is a meta-analysis on all the studies done during the pandemic, which shows that the prevalence of co-infection of bacterial infection during COVID-19 is around 8 to 8.6%. Okay, this is in contrast with the use of antibiotic usage, which reported from 64 to 83%. And this is something that we really need to look into because the prevalence is low, but the usage of bacterial antimicrobial is high. So we have to know the reason behind all this so that we understand the factors, and therefore once we understand the factors, we know how to deal with all these issues. So the challenges of doing antibacterial stewardship as a result of COVID-19 or any pandemic that can happen in our country or throughout the world is being discussed in this paper from Elaine et al. And it have listed out all the challenges that contribute to the challenges to implement antibacterial stewardship. First, it talks about the use of antibiotic in pandemic or in COVID-19 patient have unclear indication, and there's a tendency for clinician to not adhere to guidelines, and also there's a tendency of prescription or physician to use once daily dosing antibiotic. So those antibiotic with once daily dosing have a higher chance for it to be used drastically during the pandemic. This is because during the pandemic, there's a need to decrease the contact time. Therefore, once daily dosing antibiotic will be often being prescribed. Another issue is that during the pandemic, as we know, before the antiviral were finally released and finally in the market, we have to use a lot of off-label drugs, and all these off-label drugs needs closer monitoring. There's so many queries because it's off-label, and the workload of these experimental agents during the COVID-19 have also increased the workload of the AMS team. In many facilities, in many hospitals or settings, the same team that carry out antibacterial stewardship also is the same team handling the pandemic. Okay, so when the team have to really have a more tasks in the COVID-19 related tasks, they unable to focus on antibacterial stewardship. And one of the factors is because the use of experimental agents during the pandemic. Okay, so this is the challenges that we face. The other one is because during the pandemic, the surveillance of infection prevention control and also surveillance of multi-drug resistant organism were given less priority because also it's the same team have to taking up the task of related to COVID-19. So um, there's a possibility delay in reporting when there's an outbreak. There's also possibility delay in intervention that needs to be done when there's an outbreak during the pandemic. So we know that the delay in responding to outbreak will increase the use of antibiotic because during outbreak uh, we can we can control the use of antibiotic because there's a lot of cases and patients need to be treated and the prolonged duration of outbreak will increase the use of antibiotic as well. So this also will be will have a huge impact on the antibacterial stewardship program. The other thing is because of the diagnostic difficulty. As we know, in COVID-19 patient is suffering with disease that suppress the immune system. Also, they have steroid on board, and because of this, it's not easy to diagnose bacterial infection. There is um, actively ongoing uh, during the admission, during the illness of COVID-19. And the difficulty to differentiate or to diagnose bacterial infection in COVID-19 patient also one of the reason of um, challenges in implementing antibacterial stewardship. So we have to understand all these factors, then only we can determine, identify what is the best strategy to overcome all this. Steroid infection is a very interesting topic that we have to understand. As we know, one of the treatment for COVID-19 is steroids. And as we know, steroids increase the risk of infection. And there's a paper that review all the hospitalized patients with confirmed COVID-19. And this study was carried out to study the effects of steroid on co-infection. And they have divided the group into patients who received steroid and the patient who did not receive steroid. Also, we have to understand why the steroid was indicated in COVID-19 is because of the pathophysiology of cytokine storm, as shown in this screen. Cytokine storm is very um, very high fatality. Once patient of COVID-19 develops into that phase, there's a high risk of mortality, and therefore steroids is indicated in COVID-19 patient. So the study have revealed those who have steroid on board have higher rates of bacterial infection and also higher rates of pneumonia. So this explains why there's a tendency of physician to prescribe antibiotic in COVID-19 patient. And I strongly believe steroid is one of the driving factor for clinicians to start antibiotic. So I just want to share this data with you. This is from my own hospital. We noticed during the surge of the pandemic, during the Delta variant, for your information, Sungai Buloh Hospital is designated as a full COVID-19 hospital in Malaysia, and we are the ID center for Malaysia. So we noticed that during the surge of pandemic, there's also a rise in use of steroids, as shown in the graph, the below graph. this graph shows steroids in terms of defined daily dose calculation. Yeah, and when we compare with the use of our antibiotic, it shows similar trends as the use of steroids goes up. So also the same trends seen for our polypeptide. Polypeptide means our polymyxin and colicin A. We have both in our hospital, and the use of polypeptide have increased drastically within the data variant, and somehow the trend is similar with our steroid use. So this might, of course, we don't do a correlation study to see the whether this correlation is significant or not, but nevertheless it gives us some picture. And our hospital also experiencing surge of antibiotic use, especially for those once daily dosing antibiotic. In this case, is our ceftriaxone. We are full COVID hospital. At the color of a certain face, you can see the face here. This one and this one. We are full COVID hospital, and we can see the surge of ceftriaxone during that phase. Also, the same trend seen for our quinolones. There's a rise of the use of quinolones during the pandemic, and also one of the factors, driving factors, because it's a once daily dosing antibiotic. So, talking about antibiotic use in pandemic, WHO have came up with guideline, clinical management for COVID-19, and when it comes to antibacterial, they have recommended that for mild COVID-19 patient, WHO recommends against the use of empiric antibiotic. For moderate COVID-19, it can be considered unless this, it should not be considered, for moderate COVID-19, it should not be considered unless there's a clinical concern for bacterial pneumonia. And for severe COVID-19, when the patient develops shock, it does recommend empiric antibiotic as part of standard empiric bacterial sepsis coverage. So from here we know that it is not recommended, WHO does not recommend antibiotic for mild COVID-19. Yeah, and this graph highlights and summarizes the recommendation from WHO. And WHO have recommend to use this category, access category, where it already categorized antibiotic into 3 categories: access, watch, and reserve. And I will explain about this later because we have adopt and adapt this to our hospital's antimicrobial policy. So this is another paper talking about AMS intervention that we can implement during pandemic. And for Sungai Buloh Hospital, we have adopt and adapt this, and I will share the experience in the next slide. Okay, so basically, the intervention can be by controlling the antibiotic use or doing some intervention in the diagnosis so that the treatment can be targeted and shortened. So for Sungai Buloh during the pandemic, we have implement 3 types of stewardship that could be perhaps could be considered in your setting, but nevertheless, types of intervention will be very much depending on your setting whether it's suitable. But for during the pandemic, we have difficulties because we can't do face-to-face antibiotic stewardship rounds, and therefore we have decided to do the stewardship in a different manner. So one of the things that we do that I found is easier to do is IVPO switch, because it can cut down the duration of IV antibiotic and it can cut down the use of IV antibiotic. So we have aggressively switching IV antibiotic to oral, and we have came up with a guideline on the criteria to switch patient from IV to PO, and this guideline have been released in our guideline. We call it the AMS guideline. The AMS stand for Daily Integration of Antibiotic Stewardship, and we have give CME to in our hospital for all pharmacists and physicians. And we have came up with this table, which IV antibiotic can be switched to oral, and which for those IV antibiotic that do not have in oral form, what's the substitute we can use. So this is one of the, I strongly believe this is one of the AMS intervention that could be in place. Another intervention that you can do during pandemic, as we can't do AMS round, is pre-authorization or restriction, and this is adopting from the WHO access access category that I've mentioned just now. So for Sungai Buloh Hospital, we have antibiotic policy where we have categorized antibiotic into 3 groups: red, yellow, and green. And red antibiotics require pre-authorization or approval from ID. Yellow antibiotics subject to audit by AMS team. Green antibiotic does not need any approval, and no audit will be taken on them. So for red light antibiotic, one of the things that I've mentioned before is the surge of level processing during the pandemic. And after we have brainstormed in our team, we decided, for your information, levofloxacin is already listed as our red light antibiotic. And for a certain reason, the workflow to do the registration is need to be revised during the pandemic. And what we have came up is that we revise our workflow. We need to strengthen the workflow to make sure it is being followed. And one of the things that we have to know when there's a increased use of quinolones, quinolones can give rise to your MRSA infection. And we have highlighted this to the team. We have shown this data to them so that they understand why quinolones needs to be restricted. So this is our device workflow during the pandemic to ensure it is being followed, and to make sure that all use of levofloxacin is justified. And after we have implemented this, the use of levofloxacin have come down. Another one that we did is algorithm. This is to address the issues of the high use of caprazone I have mentioned earlier. So we decided, because since caprazone is being prescribed for community-acquired pneumonia, there's a high need for an algorithm to be implemented. So we have do some audit before propose algorithm, because we want to know whether there's a role of PCT to guide doctors in terms of treating CAP with caprazone. So based on the audit findings of the audit, we do a brainstorm session. And initially in the algorithm, we have included PCT as one of the biomarkers to diagnose community-acquired pneumonia. But because of some issues on the cost, and also some during the meeting, there's a need for consensus, and in the end, we have take out the PCT workflow, but nevertheless, prostacetonia or biomarkers will be the best, but it comes with the burden of cost. If we can afford the biomarkers, that will be the best way to be included in the algorithm, and this also can help in antibacterial stewardship. So we also experience shortages, and it's very important during shortages. We have a clear guideline what's the alternative to antibiotic they should use, so they then use other antibiotics that and can cause another issue of antibiotic resistance as well. During this time, we have shortages of cefepime and certain antibiotics, so we came up with this guideline. Also, one of the important things during the pandemic is the infection control, and we know that outbreaks causes increase of antibiotic use, which antibiotic stewardship is very difficult to be implemented during outbreak. So the way to go during outbreak is to enforce infection control. Then only there's a controlled use of antibiotic. So in short, what I can summarize during pandemic, the key success factor for AMS would be you have to have your technology for you to review the cases without doing rounds, physical round in the ward. And guidelines is very important to be developed accordingly, and also this guideline to be closely monitored so it been adhered to. Also, we have to have some diagnosis and biomarkers to help our clinician to diagnose infection more effectively and more accurately. Okay, so that will be my presentation on challenges of antimicrobial stewardship during the pandemic. I wanted to thank you to my team and thank you for listening.